I blame Judith for this talk, largely because I was asked to comment on the adjuvant data at a national meeting back in December. And I made one of those throwaway remarks that I later regretted about patient compliance with treatment, and said, oh, that's interesting, will you talk to the next group about it? So here we are, and I apologise if I don't make much sense. This is my favourite ever cover of Time. It was actually my birthday when it came out, and it was 11 years ago next month. And it is, I think, one of the 3 drugs that's made it to the front cover of Time because of its significance, and it's one of the most rapidly evolving stories in cancer, in that it went from a lab drug to first in man to standard of care in about the shortest time of any drug that has ever been tested against any form of cancer. And the reason for that is because it is so good. That's it. It's so effective, and literally overnight completely changed the natural history of the disease, in fact of several diseases, just clearly of relevance to those in this room, but also a form of leukemia called chronic myeloid leukemia. And it had essentially a similar effect in CML, although it wasn't quite as exciting in CML because they did have some treatments that worked before imatinib. And of course you wouldn't recognise the capsules at the bottom of that picture, but many of you will recognise the tablets that we use now. So there's the date, May 2001. What Peter's told us is about a sea change really in the way we manage GIST. It would be useful to review the first decade of imatinib use, and the story that will be familiar to many of those in this room of the management of GIST. For those of you who don't come to my clinics and don't get shown CT scans, because I do tend to show people their scans, because they say a picture's worth 1,000 words, and therefore it's easier. This is a typical GIST. It's a gentleman I treated some years ago, unfortunately no longer with us, who first rocked up in one of the surgical clinics with abdominal symptoms, and had that all too familiar story of a primary GIST, but there was already evidence of disease spread into the liver. So on this CT scan, the non-radiologists amongst you, I'm going to give you a little bit of help. The thing on the right with an arrow in is the primary tumour, and then there's a bit of sort of mottledy bit, and then the thing on the left of the screen is a very large liver metastasis. So this gentleman was a very obvious candidate for treatment with imatinib, and duly started the treatment and did what these tumours do. It shrunk, so you can see the liver metastasis is shrunk and the primary tumours shrunk, and it also got less dense on the scan, and that's another of the things that we look for. So if they're smaller, we like it. If they're darker, we also like it. Actually, one of the people I saw in my clinic this morning, I would have bought his scan. His was truly spectacular. It was one of those wow responses. But this was one that I was able to just retrieve without having to talk to the hospital's imaging system, which is a challenge at the best of times. So at 3 months, we were very pleased with the response. And the response continued, so at 6 months, it was a little bit smaller still, it was less dense, he was feeling well, his appetite had come back, he'd put on weight, and we were feeling fairly pleased with ourselves. And most people in this situation, you would then expect to go on for some considerable time deriving benefit from the tumour. Now, this is not the happiest ending, I'm afraid, and in his case, the primary tumour started to regrow after 9 months, and he wasn't really fit enough at that stage for very much in the way of further intervention. But I think it's important to remember that in the first decade of imatinib, we also had the second treatment that has been validated and licensed and NICE approved for the management of this disease, sunitinib or Sutent. And no doubt many of you will have heard of Sutent, and some of you no doubt will also have taken it. More of a handful from the side effect point of view. Now, the problem with treating metastatic GIST is I can't cure it. I'm pretty good, but we're not that good. One day Peter might be able to, but I can't cure it with drugs. We can shrink it, we can control it, we can manage it, we can stabilize it, we can keep a lid on it. But I don't talk about cure in the clinic because that would be unrealistic with drugs alone. Very occasionally we treat people with tumours that aren't quite operable, and very occasionally when the surgeons go in and remove them, there's no viable tissue there. And if anybody wants to see me dance, you should come to the Sarcoma meeting when we have one of those rare events, but it probably happens, or has probably happened less than 5 times in essentially 10 years of regularly treating this disease and very large patient numbers. Apparently, I'm not sure I believe it, but they think we have the most in Newcastle. It's because the surgeons are very well organised. But cure is unrealistic. So I think it's fair to say that whenever you're having a conversation with a patient with GIST, whenever patients with metastatic GISTs are doing whatever they do, there is an elephant in the room, and I think it's important to remember that, because we can only keep things under control for so long. We can't keep them under control permanently, and there are those black days when we have to give bad news. And it's still been a remarkable drug, and we've had, in fact, one of my patients who I haven't spotted in the room today, I suspect won't be here today, but is coming up to her 10th anniversary on treatment. So I'm confident that she's going to make the 200 club, which is one of the clubs that I have. I've got a 100 club, I've got a 150 club and a 200 club, and it's numbers of thousands of pounds worth of medication. And my most expensive patient is actually a lady with breast cancer who's in one of the pivotal breast cancer studies, and the remarkable thing about her is that she's in the 250 club, and for 5 years, 250 weeks came up for weekly treatment, because in those days it was a weekly injection. So I count these statistics, that's probably very small-minded of me. So what about cure, which is what we're talking about today? Well, you cannot cure GISTs, I don't think, without phoning a friend. And I have not that many friends, but they're good surgeons, and you cannot cure GIST without a surgical procedure, and that's very important. And there are some amazing procedures that get done and some very large tumours that get removed, and we sit gawping about things. And some of you would have heard of Derek Manus, who's one of our surgeons, and he'll show us a tumour that's going to weigh kilograms. He says, so you're going to hoik that out on your day case list, Derek. But the problem and the reason for doing trials of adjuvant imatinib is one of the cancer doctor's reflex, and it is a cancer doctor's reflex, that as soon as you see a data set for a drug or drug combination that's used to control advanced disease, you wonder if you can use it to prevent recurrence. So you see that data, and you're sitting in a congress and the data set's flashed up in front of you, and you get this involuntary twitching in your arm, which is your arm wanting to write the adjuvant treatment protocol to see if we can reduce the number of patients who relapse and ultimately die from their disease. And until the Scandinavian data were published, there was no additional treatment post-surgery that reduced the risk of death, which is our goal with adjuvant treatment. And a lot of people are very sloppy about it, but the aim of treatment in the adjuvant setting is to prevent death. And the reason for that is if you've got a very effective rescue therapy, and imatinib is one of the most effective therapies in cancer, then you don't necessarily want to expose all of the patients to it if it's not going to make a difference to what happens 10 and 15 years down the track. Because if, when they get a recurrence, you can salvage that recurrence, then you don't need to expose the whole population with the disease to the intervention, to the side effects of the intervention. So it's a very important principle that we need to keep it uppermost in our minds. So this is the adjuvant slide. It's to reduce the risk of death, and I know it's pretty grim, almost as bad as the weather, but that's true. Now, freedom from recurrence is a validated surrogate endpoint, so we look at it in some cancers, but it doesn't invariably translate into an advantage in survival. The problem, or the thing is, you get that recurrence-free survival first. And in academia, there's the mantra, publish or perish. So you don't actually want to wait for your entire patient population to reach the final endpoint. You want some sniff of the data before then so you can publish, so you can move treatments forward. But you have to show that a disease-free or recurrence-free advantage translates into survival before you can actually use that in your clinical studies. And we're going to have to watch that in GIST, because I think we could see a profusion of studies that aren't as scientifically rigorous as we might like. And there's been a bit of slide on the endpoint for the URTC study that I didn't pick Peter up on because it wouldn't have been fair. He didn't even know I was here. And when you've got good salvage therapies, it's particularly important. So the introduction of adjuvant treatment really does change the whole thing. It's a fundamental change in the management of the disease, because we've moved from using imatinib to manage the reality of disease, things that we can see on scans, things that you've all seen on scans, that are concrete, that cause symptoms, that cause discomfort and pain, bleeding, all the horrible symptoms of advanced GIST. We're managing the reality with that. We're managing problems, we're solving things, we're attending to patients' needs, patient scans, and we're now moving away from that, and we're managing risk. And risk is a much more ethereal thing, and we consider it all the time. We make decisions about risk, and we do it most of the time subconsciously. And I did it at about 2:10 as I was driving around the corner thinking, where am I going to put the bloody car? And there was a space on a meter just opposite, but I know that those are only 1 hour meters. So I did a little risk assessment and said, if I put the car there, will I get a ticket? And I thought, well, I might. So I didn't put the car there. I went a little bit further and put it in a car park, and that'll be more money, but it reduces my risk of getting a parking ticket. And that's the kind of decision that we make every day without really thinking about it. So there are risks with GISTs. There's the risk of developing GIST. Now, I don't suppose many people, other than those connected with medicine or with people who've had GISTs, think very much about the risk of developing GIST because they're so rare. And I think Peter mentioned the incidence is about 15 per million population per year, so they're a pretty rare tumour. But clearly in those people who've got symptoms and are picked up with a primary GIST, there's a risk that at the very start of treatment, like the gentleman I showed you, there would be evidence of secondary spread. For those people who have successful primary treatment, there's a risk of recurrence. And then after recurrence, there's a risk of ill health and ultimately death due to the recurrence. And there are the risks associated with treatment, because we're oncologists and we do very horrible things to people all the time. I'm not quite sure how I sleep at night, but I do seem to manage. And rather than the nanosecond calculation saying, actually, I'm going to put my car in the station car park, we need to be able to quantify risk in a reproducible and a meaningful way, so that when we see a patient who's just had surgical resection of a GIST, we can actually sit down and have a conversation that has some meaning to it and that puts that risk into context and into their context. And we can quantify it and talk about numbers and talk about the risk-benefit balance. So I'm going to give you another nice illustration because it's fun. There are two elements of risk. Clearly there's the likelihood of the event happening, and that ranges from almost certain to virtually impossible. So there is that great range. And then there's the impact of the event, which ranges from inconsequential to completely catastrophic. And you can construct a risk matrix, and you can get, if you go on the internet, you can get very complicated ones with lots of variables in them and lots of dimensions, but we can just have a very simple one for the risk of recurrence of cancers for all cancers. And I've used this in talking about breast cancer, and you can put the likelihood on one side and the impact on the other, and essentially as you go along you get into a red danger zone. So some of you may have seen at the beginning of this week, The Perfect Storm was on the television. George Clooney in his fishing oilies out in the middle of the Atlantic encountering the perfect storm. So you're watching that, you know what's going to happen. The two storms are going to meet and George Clooney's going to be in the middle of it and the boat's going to capsize and sink and everybody's going to die. It's obvious, you probably don't need to watch the film. So poor old George is up here. So that's one extreme. This is another extreme. So this is a boating lake, and these people are in a little plastic boat with lots of buoyancy, and they've got their life jackets on, and there isn't any wind anyway. And even if they did something stupid and tipped the boat, they could get out and walk. So this is at the bottom end of the risk spectrum, and there is some relevance there. I'll get there in the end. So we can construct this risk matrix that tells us what might happen to our patients. The problem is when you're talking about cancer recurrence, there are no inconsequential events. They're all calamitous. They're calamitous for everybody. They're calamitous for the patients, their families, their loved ones. They're pretty calamitous for us, actually. We don't like it when things go wrong. And I allow that little yellow box at the bottom, and that's for the recurrence that can be cured surgically, but it's not very many of them. That box is probably bigger than it should be, but that's the only let out. So at least we've only got to think what the risk is rather than the consequences of it. And of course you're all familiar with the risk factors for recurrence. There's size of primary tumour, there's mitotic activity, which for the non-pathologists in the room means that when we look at the cells that make up a cancer under the microscope, we can see how many of them are dividing, and they have what are called mitotic figures, that are things that look like little octopuses in the cells. And if you can see little octopuses in the cells, they're dividing, and you can count the number that you can see in a given size of microscope field and come up with the mitotic activity. And we also know in the more recent classifications of GIST tumours that the site of the primary is important, and basically to make it very simple, if it's in the stomach it's better than other places for the most part. And we can then grade risk as high, intermediate, low, very low, and we need to then feed that into our discussions with patients about the potential benefits of any treatment we might be going to give them. So this is just an example. This is very crude data from Roberta Di Matteo, just looking at size of tumour as a risk factor for survival, and you can see small tumours do better than large tumours. It's not rocket science, although you have to remember that rocket science is 1960s. So this was a remarkable trial. The Scandinavian group study was quite remarkable because it took a group of patients with really quite high risk disease, and it enabled more of them to be alive 7 years after they went into the trial than would have been had they not got the treatment. So that ticks the box for an effective adjuvant treatment. And in the scale of things, at 4 years, a 10% survival advantage means in real terms that for every 10 patients that you treat, one more will be alive. And that's good, that's worthwhile, particularly when the people are doing very well, because if you turn it the other way around and when you see scientific papers, we try and make everything look smaller than it is and less interesting. When you actually look at this, what you're actually seeing is the number of people dying has been halved. So it's very important. There are other important features about this. First of all, treatment goes on for 3 years, and yet we see what's called a carryover effect. That means that the difference between the people on the active treatment and the people on the placebo continues beyond the end of treatment. And that's a good indication that we are actually curing people by the use of drugs. So looking at it as an oncologist, we like to see that continued. We call it separation of the curves. It's like the Playtex effect applied to cancer. So I've said that, so I'm going to put that away. Now, there are some things that we need to think about. The first of which is who benefits from treatment. So we have these survival curves and we think about the position of the curves, but we don't, generally speaking, think about the spaces, if you like, without any lines in them. Now, this is quite complicated. Oncologists struggle with this. So if I lose you for a minute or two, I'll try and re-engage in a bit when we come to more practical things. But at any time, and we've got time along the bottom and the percent surviving up the side, at any time, all those people who are green, in that green area, are going to be doing okay whatever you've done. Now, early it's not so important because pretty much everyone's doing okay anyway, but out here, at 10 years, if we're saying that at 10 years the recurrence rate's dropping to be very low, there's a big group of patients here who didn't need the treatment, we're going to do okay anyway. And if we had a way of picking them out, we would avoid treating them, we would avoid exposing them to the side effects of the drug. So that's quite an important group. If you go to the other end of the spectrum, there's a group up here who have done badly regardless of treatment. So we're saying, oh, the treatment's really good, but despite the treatment, some people are still having a bad outcome. Some people are still succumbing to their disease. And clearly, this is a group of people who are not necessarily benefiting from the treatment. They're getting the side effects of treatment and they go on and they get a recurrence anyway. So there's a certain anger, bitterness sometimes there. Some people are more pragmatic and say, well, we did what we can, think what might have happened. And the group of people who are, if you like, the winners here are the orange group. So they're the selected group, and they're a relatively small proportion of all the patients who we treat, in whom the intervention, the medical intervention, is completely critical and alters the natural history of the disease. Now, there is a catch here, because things happen at times, and we may just be seeing a time effect. So what we don't really know is the people who are included in that little gap there. We don't actually know if there are a few people in whom the treatment's really, really important, and it really is making the difference between being cured and not cured, or whether there's a little bit of difference for everybody, and we're just delaying things by however long, by 6 months or a year or 2 years sometimes. But in fact, we're not really fundamentally changing the natural history of the disease. What will be ultimately, and we're just tinkering around the edges. And those differences are quite important. And again, we're a little bit sloppy about our interpretation of trials because we want to do as well as we can. But it's very important for the individuals on the thing. For the population, that's great. We're doing better anyway, but for the individuals, you need to know, and we can't always tell you, whether actually this is making a very big difference for you and you're one of the lucky ones, whether it made no difference at all, or whether everybody in the room's getting a small amount of benefit. It's shared out, if you like. And there are disadvantages from adjuvant imatinib treatment. So daily treatment, 3 years is a long time. It really is, and a treatment daily for 3 years is quite a burden of treatment. The side effects affect almost everybody to some degree, and clearly there are patients who seem to sail through on full dose imatinib without turning a hair and feeling great, and there are people in whom the side effects are very challenging. The other thing is that if you've got a niggle of disease sitting there and the treatment's made you feel better, that's actually quite a strong incentive to keep on taking it. Whereas if you felt absolutely fine anyway because the tumour had been taken away by the surgeon and there's some bugger of an oncologist wanting to poison you, but I say it's pickling because it's chemicals to prolong shelf life, so, but it's there. And it also gets in the way of moving on. It's back to the elephant, because it's a daily drug, which means it's a daily reminder of your illness. So there are side effects and there are costs of treatment, and I rather like this slide. The cost of 3 years of Adjuvant and imatinib is £62,940 and 23 pence. Don't forget the 23p. So it is a very expensive treatment, and it's competing increasingly now with all the other different cancer treatments that we have. So you think, bloody hell, it's a lot of money. I like spending money. I spend a third of the cancer drugs budget in Newcastle. But it does actually tick the cost per quality box. So 3 days after the meeting in London, in fact 2 days after the meeting in London at the end of November, we had the North of England Cancer Drug Approvals Group meeting, which is the regional body that divvies up money to spend on cancer. And essentially there is a two-stage process at NECDAG. We look at the evidence for a drug, and somebody presents the evidence for the drug. I did it for this one because I thought it was important. I wasn't going to let anyone else do it. Could have got Peter, but not really his job either. So we presented the evidence, and then there's a cross-examination, and there's a bit of sport in it because there are clinicians and there are commissioners on the group. And so, generally speaking, the clinicians have the clinical expertise, and the public health doctors know an awful lot about salmonella and what lives in drains, but they're not necessarily great cancer doctors, but they know how much everything costs. That's very important. So there are a number of clinicians on the group, and when we receive a clinical submission, your peers savage you, and we're vile, because that way we can get the commissioners to feel sorry, and they might give them some money to make it better. But so we had the discussion, and I got the usual questions, and then I had to withdraw, which is a shame because I couldn't have my threepence worth in the argument. And then there are two possible decisions. The first one is it's thrown out on the basis of rubbish clinical data. Well, that wasn't going to happen here. The second is it's then considered for primary care trust funding, so the usual funding streams that apply to cancer drugs. And that means in the calculation that our network pharmacists do on the back of a betting slip, that they think the cost per quality adjusted life year for the patient is around about the 30,000 that we're not allowed to talk about that NICE use. And if that box isn't ticked, we can then, and it tends to happen seamlessly, say, okay, we're not going to pay for this out of PCT funding. Can we pay for it on a temporary basis out of the money that the government gave to us when David Cameron was in kissing dog mode rather than Rottweilering tanker drivers, and came up with a cancer drugs fund? So I thought we'd get this out of the CDF, but the commissioners said, actually no, we're going to commission this properly. We're going to make this available now, which was probably going to happen anyway, but we're actually going to make it available indefinitely. So we don't just have this from the Cancer Drugs Fund, we have this from general commissioning, and that's very important because it gives patients coming along whose treatment's going to extend beyond the end of the Cancer Drug Fund the security of knowing that there is an agreement in place that their treatment will be completed. And it would take quite a big shift in opinion and NHS finances to change that decision, whereas the CDF could disappear at any minute. So, having set the background, I'm going to put you into the clinic now. And in the clinic, we have to balance the risk of recurrence after surgery for GIST with the side effects. Mercifully, we don't have to worry about the cost. It's all paid for. I've got to see the right number of patients, but it doesn't make any difference whether I treat you or not, to be honest. I can just get paid for seeing you. So we have to balance the risk of relapse against the side effects of treatment. And that balance will shift. So there are some patients who have a higher risk of relapse. And clearly in that group of patients, that balance is weighted towards, treatment, it's weighted towards that risk of relapse. And often when you see a patient with a very high risk of relapse, it's a very easy decision to say, I think you should have this treatment. And these are the reasons why, these are the side effects. Now there are other patients who will get through there and they will be more worried about the side effects. And there is, it's okay, it's just a little pill, but there is still a burden of toxicity associated with it. And so if you've got a relatively low risk of relapse, then regardless of whether or not somebody would be prepared to pay for the treatment, in your own circumstances, the benefits of treatment might be outweighed by that daily treatment, side effects every day for 3 years. So they can be quite detailed conversations, and the balance point is different for each different individual. So, and I do this obviously treating breast cancer on a very, very regular basis, and some people's tipping point is different. So you'll have people who'll be up against the wall with both hands behind their backs in half Nelsons, and they still say, I don't want your filthy poisons. And there'll be another group of patients who you say, well, really, this isn't worth it. I don't care, I want it. I want, if there's 1% benefit, I want this treatment. And in fact, there's a classic paper written by Maurice Slevin, who works in London, about different people's attitudes to treatment. And he took a group of patients, he took a group of clinicians of various different sizes and shapes, so medical oncologists, clinical oncologists, nurses. And of all those he surveyed, the people who were most enthusiastic about toxic treatments with little chance of benefit were the patients. So we have to ask you what you think. And within what we're allowed to do, we have to respect, and that's where the choice comes in. So I think that when it comes to the adjuvant treatment, our job is to set out the arguments, if you like, and we have to be, I guess, the counsel for both sides, but ultimately you're the judges, and we are consultants. That's why we're called consultants, and we give opinions. We don't write laws. We don't, hopefully, make life too uncomfortable. So it's not like this where you come in and say, this is what's wrong with me, and I say, take these. We've moved on. So I think that's the first big part of choice. This is where it gets more contentious, and it's not quite more contentious yet. So there are different perspectives on that as well. So for anyone in this room, when you're sitting there having that discussion, it's what about me? Of course it is. And you're entirely right that you should be completely self-centered when you're thinking about this. You shouldn't be thinking about the state of the economy or, you know, the number of people that we're going to have to see. Whereas most of the time I have to think about, what about all my patients? So we make population, if you like, mini population, but population of Newcastle, or we have a slightly bigger catchment area for GIST, but we're thinking about all the patients that we might see. So there is a little bit of tension there between doing what is best for everybody. For those of you who've seen Hot Fuzz, it's for the greater good. It's a great film. It's a slightly rowdy, I think it would be fair to say, but it's a great film. It's for the greater good. But we also have to be very clear that when you're in that consultation, it's actually in the context of the population. It's what about this patient, what's right for them. And you can't do that without having a bit of exploration and a bit of discussion. And sometimes you reach stalemate, and quite often you have to say, actually, I can't face another 20 minutes of this consultation. Go away, come back next week and we'll start again. That's not quite like that, but sometimes it is, because there are people sitting in the waiting area and their faces are getting longer and longer, and you have the falls people there because they're tripping them on the way into the clinic because they've waited so long to see you. So you have to kind of think about that. But you have to try and give patients time to make their own decision, to be the right decision for them. And the bottom line is, because all of those patients merge back into the population, when you're with a patient, they are the most important thing, and you do have to get it right. And if you don't get it right, or if the patient doesn't feel it's right, or they've had enough time to consider, or you've messed up the consultation, which does happen. I hope it doesn't happen very often, but you do sometimes think, oh God, I wish I could start that consultation again. I didn't get that one quite right. It's quite good just to say, okay, we'll have a week off this, come back, we don't need to make the decision today, come back and we'll make the decision next week. And what usually happens is the following week the patient comes into the clinic and says, I've made my mind up. Very often. Now, there is a little risquette in there, Because if you're being a purist, you should fill that time with nothing of a medical intervention. But sometimes you'll see patients who have maybe some other illness that you're worried about the impact on their ability to take the treatment, on their ability to tolerate it or whatever, and you'll say, okay, we'll do test X just to check that you're okay. And what happens then is that the patient comes back in a week's time for the result of the test, and rather than think about what's actually right for them, they use the test result, which is really a side issue, to make the decision. So test X gives result Y, it's a go, and test X gives a result Z, it's a no-go. But actually, they haven't really thought about whether they want the treatment or not, but you've done a test that tells you if it's feasible, and you make the treatment decision based on the result of a test that you shouldn't be allowing to cloud your judgment. So you've got to be a little bit careful about that. So the next big bit of choice is you've made that election to go on to adjuvant imatinib, and you sit there every morning or every evening, there's that ruddy blue and white box sitting in front of you, and at that point you have a choice. There's a tablet there, am I going to take it? Now, I don't know what that's like for a patient with a GIST, but I know what it's like if I get a chest infection. And you know it's there, well, I'll have it with my second cup of tea, and then one of the dogs does something and you've forgotten it, and it's prevarication. So how many people with GIST take their tablets? It's been looked at. I was surprised, actually. I thought all the data would be in breast cancer because they're all different from people with GIST. They're a very different population. It's interesting. And there's several studies, but I'm just going to pick out two that are interesting and suit the purposes of stimulating the discussion rather than what is right or wrong, because I don't know what's right or wrong for each of you. So this took 320 out of a larger subgroup of patients. They're American patients with either GIST or chronic myeloid leukemia. In fact, most of them had CML. So it's a slightly skewed population. And they looked at how much they claimed on their insurance. So it's America. So of the drug that should have been claimed from insurance, and it's quite expensive, you'd think you would, only 76% of the expected claims were made for patients on Medicare. So the inference is that patients are only collecting 76% of their medication. Now that's actually the maximum I would think that they could be taking, because I'm sure there are quite a few more who also pick up the prescriptions and then they don't take them. Now I'm just scanning around the room, but I've got one patient who did actually, with a metastatic GIST, elect to stop treatment, and that was fine. He didn't have any radiological evidence of disease. And when it came back, we restarted him as you would. We have a home care system to save on VAT, because there's a lot of VAT on £19,000 worth of drug a year. And what happens is that the home care company ring the patient and say, how much have you got left? And this guy, we'd been sending prescriptions, and the home care guys got in touch with him and said, well, why are you keeping on prescribing this guy? He's got 6 months of drug at home. So he'd been stockpiling, so he didn't want to tell me he wasn't taking it. He was collecting his prescriptions, but he clearly wasn't taking it. And 28% of patients discontinued treatment for 30 or more consecutive days in the first year of treatment. And men were more compliant. Now, I thought men more compliant, can't take any that. Women are bound to be more compliant, but I was actually going through this presentation with my wife, who's a specialist nurse, and he said, well, of course men are more compliant. And I said, well, why? Why are men more compliant? He said, well, you go in the waiting room on a Friday, you can spot all the people on imatinib because they've got baggy eyes. And I said, well, yeah. So of course the women are going to be less compliant with treatment because they don't want to look like that, whereas the men are ugly anyway. And I thought you've got a point there. So at this point, I thought I might show you a picture of my father-in-law, because if you saw him, you'd think he was on imatinib, so clearly. But maybe there's the odd patient who goes out on a bender the night before the clinic, so they've got the dark shadows under their eyes when they come and we think they're taking their medication. There is also a much smaller non-adherence study called Adagio in GIST. It was a 90-day observation study. It's a little bit opaque. But essentially they measured non-adherence by a 4-point interview. So they I think, put them in the comfy chair and brought out their tools and asked the patients whether they took their drug. They also asked patients and clinicians their perception of compliance with treatment using a 100-point visual analog scale. That sounds very sophisticated. The bottom line is you put a line in front of them and you say, what proportion of drug do you think you're taking and what proportion of drug do you think your patients are taking? And by interview, before the study, about 70% of drug was being taken by the interview tool of assessment. And of course, by doing the study at all, you remind people that they should be taking this drug, and the guilt kicks in, and when I'm in a study, I better be compliant. And that non-adherence rate dropped a little bit in the patients who were actually on study. But the perception of adherence amongst patients and amongst clinicians was that 95 to 97% of drug was being taken. So we think you're better than you are, and you think you're better than you are as well about taking the tablets. So, and that's all very well and good. And there is an element of choice, and I think we have to accept there's an element of choice, and there are people who are better at taking drugs and people who are not better at taking drugs. So what are the factors? Well, this is across cancer, so this is a big review from about 10 years ago now, but I think the issues are really pretty much the same. The factors that interfere with compliance are the complexity of treatment. And it's interesting, I was reviewing grant applications for the Christie Hospital earlier this week. It's been one of those weeks. And they were trying to do some very clever chemotherapy schedule involving an oral chemotherapy drug called capecitabine, and changing around intravenous chemotherapy every 3 weeks. So it's quite good, it's quite challenging from the prescribing point of view, but they were giving patients tablet treatment, and the bottom line was that the patients had to take tablets twice a day, and a number of tablets. So they have tablets that are 500 milligrams strength and 150 milligrams strength, and the average dose in the study daily was for those patients either 1800 milligrams, so it would be 3 500s and 2 150s, or a dose of about 1000 milligrams, which was 2 of the 500 tablets twice a day. And on one 3-week block, they wanted the people to take tablets every day, and on the other part of the block, they wanted them to take the different dose tablets for 2 weeks out of 3. And I said, this trial is unethical because of the complexity of treatment, and there are major safety concerns. And all these people from the Christie, they look at you when you're an external, and the daggers come out. If it's on a teleconference, you can feel the pain as they stick pins in your effigy. But we completely bounced this. And there's another actually guy who used to work in sarcoma at Christie called John Radford. He's a really, really nice guy. And he said, bloody hell, I hadn't thought of that, but you are right. So complexity is really important. Then there's this need for behavioural change, and what, again, we're asking people taking adjuvant imatinib to do is to change their behaviour from being somebody who's well but has had an operation to somebody who's sick because they're taking medicines, and we're asking them to adopt a sickness behaviour, which isn't necessarily a good thing. There can be inadequate supervision, because I'm not there to make you take the tablets. Now, if you're getting an intravenous drug, there's somebody on the end of the syringe, they know if you're getting it. So that's very important. There's poor communication, so we might give you instructions that you don't understand because we've told you you've got a recurrent GIST and take these tablets, and they'll be fine, we'll see you in 2 weeks. But we didn't actually tell you what you had to do. So of course you get it wrong because we didn't tell you what you had to do. Or you were waiting in the clinic for 2 hours and actually you sat through the whole of the consultation thinking, bastard, he was late. Again. Except the first appointment, it's not again. Unless they've had the week to think about it. And so they're irritated with you, and so they're not going to do what you say. And that's a natural response. I have an ex-wife, and if she tells me to do this, I'm not bloody going to do it. So there is that dissatisfaction, and we relate. We're human beings. Well, mostly we are. So you relate to people, and if you don't like what they're telling you, you're less likely to do it. And there are some people who just don't believe the trial. I don't think it works. So I'm not going to tell you, I don't think it works. Then there are serial offenders. So if people don't take their imatinib, they're not going to take their sunitinib either. And there are people with mental illness, and you think, well, do I stand there and put that in? But of course, you've got to remember that people with all cancers suffer from a huge burden of affective issues related to cancer. People who've got cancer are depressed. Well, of course you'd be depressed. And occasionally, I don't know if I should tell my secrets, but occasionally a patient gets into my clinic and is very upset, and we have to gradually winch them down from the ceiling and sit them down and give them a cup of tea and do that before we can talk to them. And they say, well, I'm really sorry, doctor, for that show of emotion. So, well, don't worry about it, because if it was me, I'd bloody be up there as well. And I think, if people are depressed about their cancer, then they're not going to necessarily be engaged with the process of treating them. So this is the big so what box. So this is, again, we get onto even dodgier ground here. Does taking imatinib matter? And that's an interesting one. Does it matter if you take your tablets? Well, we do have some indirect evidence about what might happen in the adjuvant setting in metastatic disease. So this is the French Sarcoma group, BFR14 study. It's, I think, a very brave clinical trial, but a very important one that gets very widely quoted. And they took patients with advanced or metastatic GIST who'd been on treatment for a year or more and had at that stage either CR, which is complete response, so we can't see anything on the scan, partial response, which is we can see disease on the scan, but it's a lot smaller by defined terms, or stable disease, which is anything between the tumour growing in maximum dimensions by more than 10% and a partial response. So it's a group of people who are clearly benefiting from treatment because they're still on after a year. And they said, okay, we'll take all of these people and we'll randomise them to continue drug until progression. Because particularly when we first started using imatinib, we were used to giving people filthy poisons that we injected, and you couldn't keep on giving those for 6, 7, 8, 10 years because you'd kill the patients from the treatment. So we didn't have a mindset of treatment until progression, particularly not in Europe, and I think in Europe, particularly in the UK. So they said, okay, we'll either randomise to continue treatment or to stop. And what happened when they stopped is that within a year, 80% of patients' tumours had progressed, they'd grown, compared to a relatively small number, about 30% in the group who continued on imatinib. So the take-home message from that is that if you're on imatinib for metastatic disease and you stop it, the tumour's going to start growing again, and it's kind of what we had expected. Now the reassuring bit about this study, and the reassuring bit is if you stop after a year of treatment, and the tumour starts to grow again, because you were on treatment for a year anyway, you've shown that it was sensitive to imatinib, and by restarting it, you can get back control. So there wasn't an excess of deaths, but you can't assume the same would be true in the adjuvant setting. So these people aren't going to be cured anyway, and you might be blowing the chance of cure in the adjuvant setting if you don't take the tablets. So you've got to be slightly careful there. The other thing, I don't like to get all money-ish on you because it's not really an issue, but the effect of non-compliance on health costs is really quite interesting. You think, well, a drug that costs 20,000 quid a year, if the patient didn't take it, it would be bound to be cheaper. But actually it's not. So they looked at compliance using the same prescription method, and the people who took less than half of their prescribed drug were actually costing masses more in any given year to treat than those who took their drugs regularly. Now, that is going to be biased because some of those people who aren't taking their drugs on a regular basis have other health issues that are going to cost a lot of money. But even the disease-specific cost of their imatinib-sensitive disease was higher if patients were non-compliant with treatment. So that's quite interesting, but I think provocative. So we have to think about ways of working out whether people are taking their tablets and acceptable ways of doing it. So this is a aforementioned specialist nurse to whom I'm married, speaking to a patient with breast cancer, and is saying, are you taking your tablets? And of course she says yes, but she's more likely to tell the nurse if she isn't than me, because she's much less scary than I am. We can, of course, also tell in some people taking imatinib because it does have characteristic side effects. And if you go in the literature, and I didn't dare present this, you can also do blood tests, and we can do therapeutic drug level monitoring if we were that minded. And in fact, in some places in the world, it is advocated that patients who are taking imatinib for whatever disease have their imatinib levels checked when they come to the clinic to ensure compliance. Now, of course, that's a bloody waste of time because it's, I think, a completely unacceptable form of spying. And I know that you're all very sophisticated, and if you're being seen every month, 3 months, you'll not take the drug for 2.5 months, but you'll take it for the 2 weeks before the clinic. So I won't know. So I think it's unacceptable. So you'll be pleased to know we're coming to the close here. And I don't know what the answer to this is. But I think it's clear in metastatic GIST, notwithstanding the survival data from the French, that continuing treatment is important because discontinuation leads to progression, and progression leads to misery and symptoms, and we might not be able to rescue it. It's, I think, sobering that in the US only 75% of prescribed drug is collected, let alone taken. Now, if you're not going to take the drug, fine, I don't mind, but tell me, because we could spend the money on something else. And that is important in the UK, I'm afraid, and it may contribute to treatment failure. In early GIST, so we're going to have early GIST now, like breast cancer, imatinib has been shown to reduce the recurrence risk very clearly, and in the Scandinavian sarcoma group study, there was a reduction in the number of deaths. And that's a study, as Peter's already told you, in relatively high-risk patients. But it's clearly a valid treatment. It's clearly one that we're pleased to be able to offer to people. And actually, I'm going to start going to the upper GI multidisciplinary team meeting sometimes, because I don't think the upper GI surgeons are sending me enough patients. And there is a suggestion that it may increase the number of people cured of the disease, which would be great, and reduce the burden of treating metastatic disease. And we now at least have data that we can use to inform discussions with patients about risk reduction. And that's the patients at moderate to high risk of recurrence, and a little add-in to this morning, particularly in the moderate risk group, those with a high mitotic rate in their tumours, so biologically active tumours. And it does give patients a choice. And I don't know what the answer is to compliance. I don't know whether we live with it. I don't know what you all think about it, and I'm sure you're going to tell me, and you've been very polite not telling me so far. But when I was thinking about this, I thought, what would help compliance? And I thought, I know, it would be the talking pill bottle. Thank you.